Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for a successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Welcome to episode 2 of 4 of the Practice Changing Updates, the Evolving Hemophilia Treatment Landscape podcast series. I am Dr. Angela Weyand, Clinical Associate Professor of Pediatric Hematology Oncology at the University of Michigan. I am joined by my colleague, Dr. Weyand. In this episode, we will discuss case presentations to aid in selecting the most appropriate treatment for diverse patients with severe hemophilia A. We will also provide recommendations for optimizing and individualizing recently approved replacement and non-replacement therapy options to address patient concerns and match their preferences and goals. So we're going to talk about a few clinical case scenarios and kind of looking at these two different options that I've discussed already. So this is a 10-month infant who, as he is becoming more mobile, crawling and maybe pulling up to stand, maybe even trying to walk, has developed bruising and a large goose egg after stumbling into the coffee table. He had been diagnosed at 6 months of age, and unfortunately was the first person in his family with hemophilia. He has severe hemophilia. And being the first person in his family, he doesn't have family members that are really educated about hemophilia or necessarily, well-versed or trained in intravenous administration of medications. So, as his healthcare provider, you're called after he stumbled into the coffee table, has this large goose egg, and you decide that it would make sense to treat him given this trauma and provide him 1 dose of intravenous factor VIII replacement that they come in to infusion for because they don't know how to infuse at home. But now the family, they've met some other people with hemophilia. They understand the idea of prophylaxis. They're a little more nervous as he's becoming more and more active and is already bonked himself on the head with the coffee table. So they're asking about prophylaxis and when they should be starting that. But they're really not feeling great about the idea of doing intravenous treatments at home. As I mentioned, him being the first in the family, none of them have done intravenous administration, and they are non-medical and not too interested in learning. So with this, we'll do another polling question, thinking about for this young infant who, we know is just going to be more and more mobile and be more and more at risk for bleeding, not only with his head bonks, but also into his joints. What would be the best practice approach for this patient? So, as I mentioned, they're not confident about IV treatments, and they also have heard about all of the risks associated with ports in terms of infection and thrombosis and complications related to having a port. So they also would like to avoid that if possible. So should we, A, educate and train the family about intravenous factor VIII prophylactic therapy? Say, well, you're going to suck it up. This is what we do. Your baby has hemophilia. You're going to have to learn. Should we, B, provide standard half-life factor VIII therapy? C, provide extended half-life factor VIII therapy. D, provide efanesoctocog alpha, or E, provide emicizumab. So the vast majority of people felt like we should provide emicizumab. And I think that is a really, what a lot of us would do in this situation now that we have that as an option. I think that previously when we didn't have that as an option, we would, probably a lot of centers would have placed a port in this infant or, try to start intravenous prophylaxis without a port and see how that goes. And some would eventually end up with a port. But I think now that we have this option, this can be really nice for families when their children are very young and intravenous administration is very difficult and can help avoid ports in that situation. So what do we know about using emicizumab in infants? There is a study, as I mentioned, we have additional Haven studies, and the Haven 7 study was on infants with severe hemophilia A without inhibitors. And this is data from the interim analysis. So this looked at efficacy, safety, pharmacokinetics, and pharmacodynamics. Participants had to be less than 1 year of age and have severe hemophilia A, and they received the typical loading dose for 4 weeks of imicizumab, and then received every 2-week dosing of imicizumab for 52 weeks. And at that point, they could either continue with that regimen or switch to either a weekly regimen or an every 4-week regimen for this 7-year long-term follow-up period. And what they found on interim analysis was 77 bleeds occurred in 31 patients. The vast majority of them, so 88%, were traumatic. There was 5% that were procedural or surgical, and 6.5% that were spontaneous. None of the patients experienced adverse events that led to treatment withdrawal, modification, or interruption of any type. So it seemed to be safe, and also seemed to be effective among the infants. And then, PK and PD and pharmacokinetic activities were sustained. So, some data, and I know there will be future data coming out of this trial as well, as this is interim analysis, but some data to, reassure us that this is a safe and effective option for these infants. With that, I think, providing imicizumab is a good option for these patients, and would be something to be able to offer this family. So with this, starting imicizumab, the family obviously needs to still be trained and educated about subcutaneous therapy. It is easier than intravenous. They still will require factor VIII for on-demand treatment of bleeding and around any surgeries. There's not really routine laboratory monitoring that's required, but if you are checking levels, chromogenic assays need to be used rather than one stage. And as with any of our patients, especially young patients who haven't received a lot of factor VIII therapy, ongoing monitoring for inhibitor development is indicated. So thinking about another case, in this case, we have a 14-year-old boy who's a competitive swimmer, and who unfortunately has had several joint bleeds following intense activity periods when he's in season and competing and doing, higher level swimming. He's currently on prophylaxis with an extended half-life factor VIII product, but despite the fact that it is extended, still is requiring infusions 3 times a week. He is interested in having a product that he's able to achieve high levels of peak protection, given his high levels of intense activity, but he's pretty frustrated that he's continued to bleed despite infusing 3 times a week, which hasn't been the best thing for him in terms of fitting that into his schedule. So we'll start with a polling question. For this patient who's a competitive swimmer and would like high peak levels, but is frustrated by his current 3 times a week burden of treatment, what would be the best practice option or best practice approach for him? A, recommend reducing swimming to just once a week. B, say stop swimming. C, switch to imicizumab. D, switch to weekly efanesoctocog alpha. Or E, suggest he gets treated with gene therapy. All right, we have a few different ideas. So we had about half of the group that felt like switching to imicizumab would be helpful. And that would be helpful definitely as far as his burden of treatment. We had about a third of the group that felt like switching to weekly efanesoctocog alpha, which also would be helpful for burden of treatment. And then one respondent who felt like gene therapy might be a good option. So in this case, we actually chose to start on prophylaxis with once weekly efanesoctocog because remember, this was a patient who is doing very high level activity and was having a number of bleeds and would really like to be able to get high peaks that he wouldn't necessarily be able to get with a non-factor product like imicizumab. So he was started on prophylaxis once weekly with that standard dose. He would infuse just prior to his first swim practice and typically would have actually Sunday as his off day. So when he's hitting that trough, that still is pretty high. That's the day that when he's lowest, that he also is not as active. These patients, as any patients with treatment with factor VIII, should be monitored for development of inhibitors. In the case of efanesoctocog alpha, chromogenic assays are not recommended, but one stage are. And then he also would be able to use that same efanesoctocog alpha for any treatment of breakthrough bleeds. So kind of wrapping up some of the teaching points from these two options and from this patient as well. Once weekly efanesoctocog alpha has been associated with superior bleeding prevention compared to the prior factor VIII prophylaxis for those patients in the Extend-1 study. Normal to near normal factor VIII activity for over half of the week, and improvements in physical health, pain, and joint health. The introduction of efanesoctocog alpha has significantly reduced the number of infusions required for someone receiving factor VIII prophylaxis for severe hemophilia A, and has also been shown to be effective among children in the Extend Kids trial. Emicizumab, on the other hand, is a factor VIII mimetic that is effective in hemophilia A patients of all ages and can be used in those patients that have inhibitors and those patients that do not have inhibitors. Thank you for listening to episode 2 of Practice Changing Updates, the Evolving Hemophilia Treatment Landscape. Please join us for episode 3.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.